When we look at suspected spinal injuries, we have to have that lower threshold when we're looking at the older person. The mechanism of injury that for a younger adult is not going to cause an injury, for an older adult will. So we need to look at that fall from a standing height in a younger adult. It's not a big deal. We just get up, we shake it off, we won't even call 911. But for an older adult, it can lead to a dramatic injury because the bone mass isn't there. So we have to have that lower threshold when we're assessing the patient. When we look at our regional protocols, we state that anyone greater than the age of 65, we can't use the suspected spinal injury protocol to decide not to backboard them. If we think they have that mechanism of injury, if we think they might have injured their neck or their back, they should be spinally immobilized. With older adults, the thing to remember is their bone mass is less on average, and their skin is more susceptible to injury than the younger adult. So when a person sustains a suspected spinal injury and we go to immobilize them, we want to be very careful and make sure that we pad them as we put them on whatever the appropriate mobilization device is. We also need to have a lower threshold for suspecting a spinal injury. A trip and a fall that for a younger adult is just normal trauma, for an older adult can lead to a significant spinal cord injury because the bones are not as strong, the muscle is not as strong, the ligaments aren't as strong, so they're going to be more likely to injure themselves. And the other challenge is that they're less likely to feel pain. So a younger adult will feel the pain associated with it and sense that they're injured, but an older adult will not have as much success in receiving that pain message from the injury, so they might not realize that they're having the injury. So the same injury in an older adult will have less pain. The injury might be worse because the bone structure just isn't there to support the injury. And then once we put them on the backboard, or the scoop stretcher, or the other immobilization device, if we leave them there for long, they're going to get pressure sores very early on. And that's something that we need to make sure that we assess that spinal cord injury, the potential for it early, so we can get them off the immobilization device if they don't need to be on it. How can EMS limit the discomfort associated with being in spinal immobilization while ensuring that the spine is protected? And the important part of that is padding. We tend to forget to do it. And with a healthy younger adult, they're not as likely to complain. And an older adult, they may be more sensitive to that. So areas that we should consider padding is putting a towel or one of the bundled linen packages underneath their lumbar spine, and again underneath their knees, will help them feel a little bit more comfortable in it. Interestingly, there's some studies that have been shown that the best thing to put on a backboard is bubble wrap. I can't think of an EMS agency in our area that does it, but it's actually inexpensive. You can just tape it to your backboard and then you put your patient on it. They did a study at UCLA that showed that reduced the pain of being on the backboard quite dramatically, and it's relatively cheap. Just something to think about. Fortunately, our transport times are pretty short, and people are taken off the stretchers pretty quickly in the emergency department. Again, when we're talking about the older adult, the chance that their skin is going to be more susceptible to injury, they're going to be more susceptible to pressure sores, is very concerning, something we need to be aware of as we're taking care of the patient. EMS often gets kind of cavalier about it because we're hopefully only with the patient for 15, 20 minutes, maybe an hour at tops, so we don't think that that's an injury that can happen. Hospitals are used to being concerned about that, but in EMS we tend to forget about it. An older patient is going to be more susceptible to it, particularly if they're on steroids for long term. Their skin is very brittle and they're going to be susceptible to getting this. And getting a pressure sore might sound like not a very big deal, but that then leads to infection and a deterioration of their health. Another concern with age is you'll have an older patient may become dyspneic when they're supine. So if they're lying on their back, they'll have trouble breathing. We want to prevent that. So how can we appropriately make sure they're treated for their suspected spinal cord injury, yet still be able to breathe? And this is a challenge. This is an age-old issue of what can we do, what's the best for for that patient. If we know we put them down, they're going to have trouble breathing, can we elevate the backboard a little bit? Will that help? Maybe having them immobilize and tilt them to the side a little bit. Will that help? Or worst comes to worst, is there some secondary way of immobilizing their spine? Maybe we have them in a KED and sitting upright a little bit on the stretcher. Because if we know when they lie flat they're going to have trouble breathing, so we have to do something to treat the suspected spinal injury as best we can, yet still allow them to breathe. It's not an ideal solution, but it's certainly better than not treating the backboard or not treating the suspected spinal injury to allow them to breathe, or treating the suspected spinal injury and then making it very difficult for the patient to breathe.
Sir, we're holding your neck for C-spine precaution. Try not to move your neck.
I'm going to check his extremities.
Sir, my partner's going to apply a cervical collar to your neck to immobilize. Try not to move. Is that comfortable, sir? Is it yes or no?
Yes.
Good. All right, log roll on my count. 1. Everyone ready? 1, 2, 3.
So you're going to check your back. Let me know if this hurts.
No. Okay.
Everyone ready? Rolling back on 3. 1, 2, 3. Put the towels over his head.
So I'm going to head underneath your knees.
A little more to there. Good, good, good.
Thank you. If you guys
Pull this towel right in here.
all right.
I'll recheck his pulses and movement for you. Sir, can you move your hands for me? Squeeze my fingers. Can you wiggle your toes for me? All right. CMS is intact.
Good.